Can you all see that okay?
Yes.
So today I'm going to talk to you about the PALS line. I know I've mentioned this phone service for clinicians before, but I'm going to go into a lot more detail today about what the service does. And then I'm going to present 5 cases from real phone calls I took, and we can kind of talk about that a little bit. So that you can kind of understand how to use this resource. And it's really a resource that hopefully will be helpful to folks. So this is sort of our official flyer, and this is the telephone number. It is actually a cell phone that I carry with me Monday through Friday. I actually carry it with me on the weekends too, but I try not to answer it outside of work, but I have been known to answer it on the weekends. But it is really 8 to 4. It is a confidential line. People can use phone numbers. It was really designed for any provider, any clinician, any school to really reach out to talk to a child and adolescent psychiatrist about a student or a client or a patient in their care for kind of guidance and advice. It was really, and we'll talk a little bit about the history of telephones like this and what sort of the intent of the service is, but our line opened in 2019 based on a model of from other services. But this is the phone line, and it rings directly to me. There's no middleman, which is actually kind of a different approach, and most of the clinicians that call the line regularly really like that. I've even gotten compliments that there's less red tape than some of the other services, which of course I liked, but it's really designed to kind of give people quicker access to support, or at least point people in the right direction. And so while these 5 cases are sort of a little bit focused on medicines, because a lot of people are asking about medication referrals, I actually get a lot of questions about how to connect people to therapy or services in the state. And so I'll share some of those as well with you during this phone call. But I have a lot of repeat callers, people that are sort of following, and some of the cases I've talked with them over time as they're waiting to get in to see someone, or lots of times what the service has really done is really helped kind of extend a lot of pediatricians' comfort with writing medications for kids. And oftentimes the kids get better and they end up not needing to come to see psychiatry too. So it has lots of goals. But here's the official flyer. Here's the official phone number. This technically is for people only in West Virginia. It is paid for a grant through Aetna Better Health as part of their outreach program, and Aetna Better Health covers West Virginia Medicaid. I'm not gonna refuse a call from like Ohio or Pennsylvania or upstate, but it really is open to anyone in West Virginia. So the idea behind this line is just a lot of the challenges in meeting the needs of pediatric mental health. I will say this is pediatric, but I also have people that are family practitioners that see kids and have called me on the kids line, but they've also called me about adults, and I'll try to be as helpful with that as well, although it is really for kids because there's less access. And this is because looking at some of the data that we have in our country, over half of children that need mental health care services just never receive them. For a variety of reasons. But one of the huge barriers to that is there really are not enough providers anywhere in the country to meet the needs. This is well before COVID. COVID has certainly worsened it with the increase of needs, but even well before COVID, pediatric mental health has been noted as the most underserved specialty, and West Virginia, being a rural area, has never had enough providers to meet the need for decades. And a lot of challenges in West Virginia with an aging workforce have shown that at least a lot of the child and adolescent psychiatrists, many are over 55 and at risk of retirement, and that has been a challenge as well. And so the idea with this phone line was to try to extend the needs and confidence to other pediatric providers to sort of support them. And so it's a phone line that can kind of allow pediatricians to bounce ideas off, ask questions, help fill in some of those knowledge gaps, to kind of be like a support to the pediatrician, whether it's a med side effect question about whether it should start medicines or how to access treatment, or kind of what to do while they're waiting on a specialist. And that's where it has often filled the gaps. The vast majority of people that call are pediatricians, but I get phone calls from schools. I have gotten phone calls from APPs. I have gotten calls from, at one point it got published online and people thought it was like I think the mobile crisis. I've gotten it from all different places. I always try to be helpful, but the vast majority of folks are people seeing kids in other health situations or school situations. So the program started in 2004. The first phone access line was in 2004. And so they were really, again, having this goal. And these are just some numbers that kind of show some success. So in 2016, they looked at, kids that received some type of treatment. And you can see that in 2016 that some of the children that lived in a state with a telephone access program or partial program, and we'll talk about what that means in a minute, really did show some increase of ability to have some access to some mental health specialties training compared to those states that didn't have a program. And also, and so looking at that data, about 12% of kids with full programs receive some care, whereas it was still less than 10% in the state that didn't. So lots of states are now increasing these programs. They're different, and a lot of it kind of depends on funding and what funding exists and how it's staffed. Ours is a pretty cheap version. It literally covers the cost of cell phone and doesn't really pay for any support staff or anything like that, but it at least covers some of the basic costs. Some of the programs are a little bit more substantial, and that they have some staff that collect some data, or they have maybe a person that answers the call and forwards it. And so there's a little bit of differences. So this one's just me. And so it really is a dedicated hotline for primary care physicians to consult with a child and adolescent psychiatrist. So we have that. I have on a few occasions arranged face-to-face psychiatric assessments, but often we have very long wait lists. So I certainly have fast-tracked people that really have been urgent from those phone calls. Most of those kids are actively psychotic. A lot of times if a child's actively suicidal, that direct referral is to send them to the emergency room. But we have streamlined some referrals. I give out a lot of information about other community health resources in the state, and some of this is localized, some of it's state-based. I personally have a lot more knowledge about North Central West Virginia, although we've come more online with more state-based programs, so I've been able to deliver more statewide information. And then really a big part of the goal is to really increase sort of education and knowledge about sort of how to diagnose and treat and deliver some mental health services consistently. And lots of times, this is the other area, lots of times there's still a lot of stigma about coming to child and adolescent psychiatry. And so for a lot of people, they'll never come to my office. They would much rather see the person in their community. And so this can really help increase access through healthcare pathways that exist. And I think the best part about the job of running this phone line is just, I think it's really helped increase the pediatrician's confidence and their own skills. And I've really gotten to see pediatricians and primary care clinicians really grow and their comfort level with the medicines. I've gone from, I have never written this prescription ever, I'm terrified, to, I remember you told me how to do this, I tried it, it worked, but now I don't know how to do this. And seeing their confidence grow, and then them having success and seeing their kids get better is truly one of my favorite parts about this. And as I said, I have probably about 20 or 30 pediatricians that they're like, I think I call you all the time. I'm like, no, you don't. You can call all the time, that I've developed a relationship with, that are repeat callers, and it's really fun to have that too. But anyone can call. All right. So our phone line officially opened in October of 2019. To date, I've taken about 250 calls. I do try to log the calls. It's not very formal. I just note for Aetna to show that I'm doing something. I'm not taking data on who called or what it was about. I probably should. Those of you that are involved in research, it's a great research project. I just have not been organized enough to have a more systematic way, but I have logged 250 calls officially through that program. The hours are technically 8 to 4, but it's a private confidential line. People could text, people can leave a message. I will usually call them back by the end of the business day or the next business day. And lots of times, if I'm not in between patients, I will answer the call right when it rings. So it is not a huge wait. So before I'm going to just go through like some examples. These are real life examples of calls I took in the last month. I wanted to just ask if there were any questions about how the line worked before I went through some examples. I think it's a lot simpler than people think it is, but I think it has really big impact. So does anybody have any questions at this halfway point before we go into some of the cases? And again, as we go into the cases, these are cases as the pediatrician or clinician presents them to me. I have not actively seen the kids. Now, interesting enough, I've done this long enough now that sometimes I actually have met the kids that they're calling about, but that's not always the case. So sometimes it's questions too about, I saw this kid on my schedule. It says they're hearing voices. I don't know what to do. And sometimes they'll preemptively call and we'll talk about what you should ask. Or what to do ahead of time. And then they'll call back after they see the kid. So this can go a lot of different ways. I did, because I gave some medication lectures last year, I picked calls that talked about different medicines and different conditions. So we had a little bit of a variety, but this will probably highlight some of the lectures that you've heard me give on medicines before too. All right, so this is my this was my first example. This was a pediatrician in Parkersburg. The insurance formularies change frequently. And one of the things that happened in January is that Vyvanse, which is a medication that has been on the formulary for years, changed. And I got a lot of phone calls about this. So this was a 14-year-old with ADHD and a borderline intellectual IQ score, had been doing great on Vyvanse, 40 milligrams. And the insurance stopped covering it. And so the replacement medication was supposed to be Adderall XR. And so the pediatrician had already tried 15 or 20 milligrams, which is the equivalent dose of what the Vyvanse should have been, and it just wasn't working. And of course, it was very frustrating because the kid had been doing great, medicine changes, this replacement isn't doing what it's supposed to do. So the student was getting more agitated at the end of the day, was having more of the withdrawal dysphoria, the withdrawal moodiness when the Adderall XR wore off. And she's like, I just don't know what to do next. So I spent some time talking about how Vyvanse was different than Adderall. So Vyvanse was a prodrug. It is requires a second pass metabolism through the liver. So it doesn't work as fast. It takes about an hour to kick in, and it lasts much longer than the Adderall XR. So one of the problems I think that was happening is the Vyvanse was lasting much longer than the Adderall XR was. And because it's a prodrug and has a different release pattern, I think that the Vyvanse had a smoother off, so to speak, than the Adderall XR was. And one of the common things you see with a 50-50 split, which is how the Adderall releases. So Adderall XR 20 actually releases like an IR. It's like 10 milligrams in the morning and 10 milligrams after lunch. So the drop off at the end of the day is a little bit more, people feel it. And that's that phenomenon of withdrawal dysphoria that may have existed on the Adderall XR instead of the Vyvanse. So we talked about, well, one of the things you could do to extend the length of this medicine is, because it doesn't last as long, is let's add a short acting form of Adderall about 30 to 40 minutes before that XR falls off. We can pick a smaller dose, 10 milligrams would be closer to what works, but we can pick 5 or 10 and see if we can extend the length of action of that last dose to get them up to about the 12 hours the Vyvanse was getting. And because we went to 5 or we did 7.5 or a little less, that drop off won't be as significant. The other thing you can do is pick a different stimulant. So all stimulants are methylphenidate or amphetamine-based products, and they largely all are packaged in a fancy way to release differently. And so the methylphenidate product that has sort of the same timing, it's a different agent, but the same timing properties like Vyvanse is Concerta. Now, Concerta is not a prodrug. It actually works through a pump mechanism. It's called an oro system. It also means you have to take it through your stomach, and the pH, the ion differences in the stomach kind of like pump the medicine out of the pill. And so as a result, you get a kind of smoother release as well. So again, it takes a little bit longer to kick in, but it doesn't have as full enough dropout. And Concerta, in theory, is about 10-hour max length, where Vyvanse is 12, a little bit longer maybe than the Adderall. And Concerta was also on the Medicaid formulary. So we talked about that as an option as well. So again, just a couple learning points from this case is that formularies really do change really often, and you do have to unfortunately take people off a medicine that's working. It's usually driven by cost and sometimes availability on these things, and so it is really helpful to access a conversion calculator, because if you do have a replacement product, you want to try to get the dose as close to equivalent of the product that you're switching to. And you can type in a Google search stimulant conversion calculator, and it will often do that. But typically, if you're on an amphetamine product, you try to switch to an amphetamine product. If you're on a methylphenidate product, you try to switch to a methylphenidate product and get it close. But every pill has a different release pattern, a different sort of timing, and getting some comfort level with those differences can really be helpful. And so this is one of those slight differences between Vyvanse and Adderall. I think the release pattern and the timing was more at play versus the actual medicine. Any questions about that case? And I don't get feedback on whether it works unless they call back. And then often they'll call back and say, that really did help, and I learned that. And so it's kind of delayed gratification, I guess, in hearing back. But this is, these kind of things are often very, very common questions about stimulants and timing that I get. Again, just a few other learning points. Most of the products are time dependent, and intermediate products last about 4 to 6 hours in length. There's some intermittent ones that are 6 to 8 hours, and then there's some long acting ones, but the long acting ones can have a kind of a 4-hour difference sometimes, in 8 to 12 hours. And again, just some basic conversion rules. Vyvanse is an exception to this. Vyvanse does not obey this rule. So Vyvanse always has to go through that calculator because it's a little bit harder to convert that. But if you're on generally a methylphenidate product, 10 milligrams of methylphenidate equals 5 milligrams of a Adderall product or an amphetamine salt. And then Helpline, which is dexmethylphenidate and methylphenidate, also follow that rule. So if you remember this, you can kind of do a lot of the conversions directly in your head, but until you get comfortable with the ones that don't obey the rule, the online calculators can really be helpful. Okay. This is one I just took, I think about a week ago. This is a pediatrician from Fairmont. He had not seen the young lady yet, but the mom had called the office and had commented about, she was worried about her daughter vaping, had found a bunch of vape. Pediatrician's like, I haven't talked to the kid yet. I don't know how much she's using. I'm not even sure she wants to stop. I'm going to bring her in to talk to her. And I just kind of don't know if there's anything we can do. If she is interested in quitting, if she is interested in stopping, can I even use nicotine products in a kid, or how do I calculate vape? And can I do this? And so I was like, yep. And we did a lot of walking through kind of what to ask. So I sort of recommended, really find out how much she is using. Of course, talk to her separately without mom, which was planning to do anyway, but we really talked about making sure that you ask about all nicotine products, whether it's smokeless tobacco, cigarettes, or vape and e-cigarettes, and try to get a sense of what the brand name of the product is that they're using, how much they're using. Because what we're really going to try to do if she needs treatment is we really got to find out how many milligrams of nicotine on average she's using a day. And then not only do you want to assess for that, but you really want to ask, does she have withdrawal symptoms? And a lot of kids these days are going to the bathroom in between classes, vaping in the bathroom, because they're literally in withdrawal in the middle of the day, and because they're in nicotine withdrawal. And so we talked about asking about that, asking about, have you tried to stop before? What happened? Do you want to stop before? We talked about using motivational interviewing to kind of see what was important to her, and kind of if vaping was sort of at this point, to be cool or to be with friends, or maybe we were vaping because we just felt so bad when we didn't vape, or if we were using it to focus, or if we were using it to calm ourselves down, or just really trying to understand what was driving it. And then I said, and this was sort of the big educational point, is, vape products have a lot more nicotine in them than traditional cigarettes. And actually, a lot of kids really are struggling to quit. And some recent reports of national surveys that came out in 2021 showed that almost 22% of kids are using e-cigarettes daily and really can't stop without some support, because they really are having daily use. And a lot of the pediatric societies, from the American Academy of Pediatricians to my organization, Child Psychiatry, have really issued statements that says lots of kids may actually need nicotine replacement because they can't stop without it. And how you do that is sort of what we went into next. So if you are using 25 milligrams of nicotine a day, and I'm going to talk to you a little bit about what that means, that is really considered high use, and may really justify the need for nicotine replacement. In kids specifically, the patch has been the best studied agent to help kids reduce their nicotine use, plus or minus the use of nicotine gum. So how you would do that is, if you can calculate how many milligrams of nicotine she's using a day, you would make the patch try to meet as close as you could. It comes in 21, 14, and 17 milligram patches. You try to combine the patches to meet her daily use. And let's say she's using 21 milligrams. You could give her a 21 milligram patch as the prescription. And then on top of the patch, you would say, you can also use this piece of nicotine gum, and the gum comes in 2 or 4, every 1 to 2 hours when you had a craving. And I even write the medication form so that kids can have nicotine gum in school, because they would get in trouble if they didn't have that note from me. And I've had schools honor that so that they can chew their gum in school and not run to the bathroom and vape. And then what you would do over the first few weeks is calculate how many pieces of gum they were using for their cravings. And then if you were using a lot of gum to do the breakthrough cravings, you might have to add a little bit more patch to try to cover what their needs are. Because the goal is for them not to reach for their vape or not to reach for a cigarette, to cover the cravings. In the state of West Virginia, you can get nicotine replacement covered by the quit line. Now, not everybody that answers the quit line phone knows that. And I've had some parents and kids call and say, they told me
what they did and didn't want us to do with that, because they said that.
And I said, yes, they may. So I warn people they could say that, but I say, please if they tell you that, let them know that there's a special form, if they check with their supervisor, that they will cover it if they're under a doctor's care or have the parent's permission. And then they'll fax me the form and I'll fill it out and they will still cover it. So some parents who are supportive will go help the child buy it on their own, because nicotine products are over the counter. but we have been able to get some kids on Medicaid nicotine coverage if they meet criteria for that. So that is the quit line. It's the same number adults call, but you can still access it for a teen. Bupropion or Wellbutrin, which modulates dopamine and norepinephrine, has also been studied to help reduce cravings with regards to nicotine. We often use it for depression in young people as sort of an off-label antidepressant, and it also has some good data. So we talked about that could be an option as well. The dose of bupropion for smoking cessation is 150 milligrams for the first 3 days, and then up to 300 milligrams, which sounds like a lot if you're doing it for depression, but that's the treating dose to get the cravings high enough. It takes about a week at the 300 milligrams to be effective for the craving. So you kind of have to tell people to not expect anything the first couple of days and kind of plan ahead for about a week after they've been on that 300 milligram dose. Varenicline or Chantix does not have data in pediatrics. It has safety data, so it doesn't seem to make kids sick or cause too many problems, but it has not shown efficacy data. So we tend not to use that one. So I talked with him about both of those options depending on how much she was using. So the other sort of, again, points is just really lots of people are seeing these very high levels of teens vaping. We are seeing really high amounts of nicotine being vaped compared to what we used to. And this is because you can really manipulate the vape product to pack in more nicotine, so to speak. And I'm going to show you a picture here of comparing some of the products. And again, it is really important that nicotine, although that's not often advertised in these products, nicotine is the drug of addiction that is causing the addictive process and the withdrawal symptoms. And oops, I skipped one. Sorry, guys, I gotta figure out how to go back.
While you're getting back, how are these kids getting access to these? It might sound like a naive question, but
well, in West Virginia, my answer would be that often they're everywhere. They weren't actually very well regulated until more recently, so kids could actually go buy them. But lots of people thought they were safe and didn't realize you could get addicted to vape. And so lots of times, sometimes the vape or even the cigarettes are coming from their family members, sometimes very well intentioned to try to get them off of other tobacco products. But they're pretty ubiquitous around the world. I think we are seeing some decrease. I don't know how much of it's related to COVID. Or there was some new legislation that came out a couple of years ago to increase the use of tobacco products to 21, and that may have helped it in high school students, but it is still everywhere, especially in West Virginia. If you haven't been in a vape shop, it's really enlightening to walk into a vape shop and see all the products. You can make it like a field trip. It's pretty impressive.
Oh my God. Thank you.
Yes, that is an excellent question. And it also really sort of begs the fact, and this parent did not smoke, but actually when you're trying to help a kid with vape or tobacco, if their parents or their family members are using, my other answer is you actually probably need to support the entire family and write prescriptions for the entire family to try to stop, because the child trying to stop when they're still around active product is really, really difficult. One, because they're triggered by the smell or seeing it, but also you can't really motivate someone if they just think they're not supposed to be doing it because of their age. That never works with a teenager. So often you have to really understand the reasons, and actually it's really motivating for a kid to see an adult try to quit. In fact, a lot of the kids that I've had success with agreeing to some support have said, I remember my mom smoking for years. She worked really hard to stop, and she told me that there was help, and I knew she could do it, so I'm willing to try, is actually much more helpful. I have never, maybe once or twice, I have never been successful at the whole, well, I'm old enough to vape, so I can do it, but you can't. I've never really had much luck with motivating those kids. So it really is one that you can look at the whole family for.
That's really a good point. That's fair. I think it's really interesting that some people are encouraged to do it more because their parents might have, and some of the opposite. I'm the opposite. When my parents, like, was a really heavy smoker, they don't anymore, but they've gone to like cigars, and because they did it so much around me and I just hated it, I'm like I'm like turned off by it. But I think it really is interesting. Some people, that's like nostalgic probably, and makes them feel like at home. And so I think that's a really interesting point. And also Mariah put that they're able to buy it online too.
Yes.
Some are ordering online. So
yeah, you lie about your age and off it goes, right? You're just trying to collect your taxes, right? Yeah. And if you buy it with a parent's credit card, because you've been giving your parents credit card, you look old enough, right? There's lots of ways to do it. But a lot of people don't recognize that nicotine is in vape. I mean, vape was often sort of, oh, it's water vapor, or it was, and this is a whole separate topic we can do next time if people are interested. I could talk about tobacco and vape forever and would be happy to do that. But there's a lot of people really don't know that there are significant health risks with vape, and that we're seeing lots of the same problems. But the hook, the addictive hook, is still the nicotine, which is why people are coming back and back to these products. The nicotine is not what causes the health problems. The health problems come from what the nicotine is in, and I'll just leave it at that. But really understanding the nicotine content really matters. So here's just sort of a little bit of information about how to calculate that milligram amount. 1 cigarette is 1 milligram of nicotine. One pack of cigarettes has 20 cigarettes in it. That's 20 milligrams of nicotine. 1 cigar, one of the big fat Havanas, is about 20 milligrams of nicotine. So that's about a pack of cigarettes. An hour on a hookah in a hookah bar, going through the whole hookahs, about 20 milligrams. Again, a pack of cigarettes. Vape products come in pods and cartridges. Some of them are pre-filled that you can buy and immediately use. Some of them are you can mix yourselves, and they also tend to have very high levels of nicotine in them. I didn't put this on here, but 1 can of snuff is actually equal, like a Copenhagen can is actually equal to 4 packs of cigarettes or 80 milligrams of nicotine. So if you have a pediatric patient using a can of Copenhagen a day, which happens a lot in West Virginia, that's almost 4 packs of cigarettes and nicotine. That is a lot of nicotine. But I'm going to show you this picture that I love. This is how much milligrams are in some of these pods. And if you go into these vape stores, there's literally hundreds of different types of vape. And they all have, of course, very cool names like Puff Bars and Soren and IQOS and things like that. But they all have very large amounts of nicotine in them. So a Soren pod is almost 90 milligrams of nicotine. A Puff Bar is 50 milligrams. And you ask people how long it lasts, and a lot of kids are using like a pod a day or a Puff Bar a day, and they're using substantially more nicotine than we're seeing. I mean, if you think about the aversion of a cigarette, having a cough and a smell, it burns. It takes a while to work up your tolerance. When you're using a chemically manipulated product so that it's sweet or it doesn't burn or it has a flavor in it, people are packing in a ton of nicotine without the adverse effects and kind of getting up to higher levels faster. Okay, I think I skipped something. Okay, so here's my third case. This is a 14-year-old. This was actually an emergency room physician in Somersville that called. She was sent to the Somersville emergency room, I believe, by her local school. She had made some suicidal comments that had come to the school's attention from social media. And she had a history of depression and anxiety and complained about bullying in school, admitted to suicidal thoughts, but the emergency room had not done a risk assessment, hadn't asked her about a plan or intent. They really just knew she was suicidal and they were looking for a bed. She had actually waited in the emergency room for 48 hours, had not been able to find an inpatient bed, and her parents just really wanted to take her home. They were tired of waiting. They really didn't know that she would benefit from the hospital. And they're like, the question kind of was like, well, what do? We don't even know how to assess her suicide risk, or how do I do a safety assessment, or how can I let her go? And so they were not comfortable with less. So we did a lot of things in this phone call. So the first sort of thing I did was really talk about, well, what is a risk assessment? So just by virtue of being suicidal does not mean you need an inpatient bed. I think that's a really important thing. Sometimes they're like, oh, you're suicidal, you need inpatient. No, that's not what that necessarily means. If you have suicidal thoughts, you need to talk to the patient about it, get more information, really decide if there are alternatives that can be helpful. How do we manage safety? It's really a discussion. And so we talked about, tell the patient, thank you for talking about it. These things are hard to talk about, but we need to understand this more. You have to directly start asking them, well, how often have you had these thoughts? When did they start? How have you thought about what you would do? How close have you gotten to do it? If those thoughts occur, do you tell someone? Have you tried to hurt yourself before? Have you attempted suicide before? What happened when you did? Ask about things that happened. Was this the bullying that's triggering it? Is there been a loss? Are they feeling hopeless? Do they have a history of impulsivity? Do they have anxiety or depressive symptoms? Is there substance use? What is the context of the suicidal thoughts? And then, what are their reasons for living? You know, there are lots of people that have suicidal thoughts that would say, well, I would never act on that. That's why I told my mom, I want help. I don't want to feel that way. And I don't have any intention of doing it, but I know that that's not a healthy feeling and I want to get better. So you have to ask about their support, their reasons for being alive. How do they keep themselves safe? Because often kids have been struggling with these thoughts for a long time. They have been keeping themselves safe. And then you sometimes have to talk to the parent separately as well. Sometimes kids don't tell you they wrote a suicide note. Sometimes kids don't tell you all the facts. But sometimes they have great communication, and sometimes the family knows all those things. And sometimes mom's like, yes, she's come to me every time, and I really think she's depressed. We really want to get her into help for that. So you do a risk assessment. There's official fancy ways you can calculate risk, but these are the elements that would help you determine that. You also have to see, can I make a safety plan? So what's a safety plan? A safety plan is a contract made with a patient and their guardian about how to manage those thoughts. First part of that plan is, if there are medicines in the house, lock them up, especially the over-the-counter stuff. If the child has access to a gun, or they're talking about hanging and they have access to rope, you make a plan to remove those things. It validates that the kid is triggered by this. This is a really important part of safety. Most kid suicides are not planned events. They're often impulsive and they often reach for what's available. So if you have a kid with no prior attempts that isn't having a plan or telling you what they would do, helping secure the environment and have a conversation with their family can be most important. You talk about, well, who would you tell? What helps when you have these thoughts? Lots of kids would be like, I would tell my parent, I would tell my older sibling, I would tell this person. A lot of kids will say, I just want to talk to somebody. You can give them the suicide hotline. You come up with a plan for what to do with the thoughts, and then you work on having them check in with each other every day. I want you all to talk about how these thoughts are doing every day, how you're doing in terms of safety. If at any point that safety is getting to the point that you don't feel safe with that plan, that's when you need to come into the hospital or come back to the hospital. And then we sort of see, well, what can we fix? How can we connect them to services? So if they're getting bullied, what are services or things you can do to help with the bullying? If you're depressed, how do we get you help for depression? And we connect them to services. So I give people this information. This is free. This is online. This is all from the NIMH, which is the National Institute of Mental Health. It has all the suicide screening questions online. So if you forget what I tell you on the phone, you can pull this up and it has all the questions to ask. It even has some worksheets and risk stratifiers where you can say this kid's high risk, this kid's low risk, and ways to work through those safety plans. So this is all available to clinicians for free. We say, asking about is the first step. Then we work to keep them safe and connect them. if they cannot be safety planned, if they cannot get connected in a way where they're still guaranteeing your safety, those are the kids that need hospitalized. The ones that have alternatives, the ones that are lower risk, the ones that have supportive families and can talk about the safety plan in a way that's helpful, is actually much better to help them get back home and connected than to admit them. Because for most kids, especially in rural West Virginia, admitting them is a really long process where they get sort of sent away without their parents, often far from home. It can be incredibly helpful and it's necessary, but it may not be the most appropriate level. It's a higher level of care than what some kids need. So it really should be an immediate, you're suicidal, you need the hospital. There's lots of steps that need to kind of be in between. So here are some other things that we give out to people. There's a national suicide helpline. This is the service that will be transitioning to the 988 service. I don't know if anybody has heard about that, but July 1st, there will now be a mental health emergency line. So we call 911 for medical emergencies, but there's going to be a 988 line starting July 1st that will connect people to emergent mental health help. There's a text line for kids to use for suicidal thoughts. We talk about locking up weapons, firearms, all medications, who to identify, to reach out to, and really working on strengths, check-ins, things we can do to be helpful. Lots of times kids in this example, bullying, they just feel supported and come up with a plan to address the bullying with the school. They're gonna feel a million times better. I will also add, it's not on this form, but a lot of kids get triggered by social media. And we'll talk about maybe taking a social media holiday or social media vacation and just, focus on themselves, be selfish, sort of put the world outside and they feel better. That can be really helpful for people too. This is the number in West Virginia. So if you have a child in the emergency room or a pediatrician's office and you just don't know what to do, and you need to get them plugged into therapy services, mobile crisis, this is the emergency line in the state. My access line is to talk about medicines in the plan, but I give this number out all the time. This would connect you to emergency services, mobile crisis. This can connect you to the CSUD waiver if you have kids that have really complicated things. This is that 24/7 bat phone that was created by the state of West Virginia. So if you don't have anything, you don't know what else to do, this is the phone number you can call in the state of West Virginia. They will walk through, you talk to a mental health provider live any hour of the day, and they can walk you through the best appropriate treatment. They may tell you to take them to the emergency room. They may send mobile crisis to your house. They may schedule a follow-up appointment. So this is really a really important number in West Virginia, and I give this number out a lot. All right, this might be the last one. I'll try to be fast. This is a patient with depression, had done well on escitalopram 10 milligrams for a couple of years. When the pandemic began, they began having more OCD symptoms with hand washing, fear of germs, contamination. They're having more panic attacks in public, problems returning to school, fear of illness, getting COVID, lots of anxiety, but hadn't had their depression come back, had been virtual schooled the previous year and was struggling. This was to get back to in-person school because they weren't offering the virtual option. And the question was, should I change her medicine? What should I do? Should I just increase the dose? Should I change the medicine? And this is also a very, very, very common story that we've seen. So I said, well, first you can increase the dose of Lexapro. You could go up to 20 milligrams. With SSRIs, the higher doses of SSRIs are better for panic and OCD symptoms. Many of you have heard me say that. The lower doses tend to be more targeting depression. The higher doses can be more helpful with anxiety. So one option would be to really maximize this. Technically, Lexapro has a major depression indication. It doesn't have that OCD indication, but it still theoretically has the same mechanism of action of the SSRIs that help OCD. So she's already on this medicine. You certainly could try to augment it. Then I said if the higher dose of Lexapro isn't helpful or there are side effects, I would probably switch to Prozac or Zoloft. Those are both the FDA indicated ones for pediatric OCD. But remember that rule about the dose. It's often the higher doses that you need to do. So what you'd have to do is come down on the Lexapro while you went up on the new medicine, and talked about these being the dose ranges that often target that OCD. And so again, It's important to, again, remind people what the FDA indications are, but also to kind of think about what the limits of FDA indications are. So in this point, while she had good success with Lexapro for the depression, which Lexapro is FDA approved for in pediatrics, you don't always have to just change that medicine, even though that it doesn't have the OCD indication. It certainly might be beneficial to do that. However, there are 4 medicines that do have a pediatric indication for OCD. So those 4 medicines are the fluoxetine, the sertraline, the clomipramine, and the Luvox that you certainly could switch if the Lexapro didn't help. And again, these are the ones that are FDA approved for depression. So fluoxetine 7 and up for depression, escitalopram 12 and up for depression. But again, SSRIs treat both, and we often know that that higher dose is needed. So remember, with these medicines in kids, always start low, always go really slow, but they still may need to get to the higher doses to get full resolution. And then my favorite line that all of you have heard me say is, if you expose a child to a medicine without getting to the right dose, you're exposing them to all of the risks and none of the benefits of that medicine. So be mindful of that.
We had a question come in, Dr. Swagger, if you don't mind. On patient number 4, would you consider going higher on the escitalopram
Yes.
before switching?
I would. I actually, if there's no side effects at all, no activation, no agitation, and they're on it for OCD, I will take it up to 30 milligrams before I consider it a failure, specifically for OCD. Yes. And just to give you a little information, escitalopram is like the active isomer of Celexa or citalopram, and it has been studied for pediatric OCD in some evidence base up to 60 milligrams of Celexa, which is 30 milligrams of Lexapro equivalent. So there is evidence to use it for OCD. It just doesn't have that FDA approval. So I will take it up to 30 if again, there are no side effects before I would consider it a failure. Absolutely. Okay, last one. This was a pediatrician from Bridgeport. This is a pediatrician I knew really well. They had called me multiple times, were super open to trying things. And I set the stage for that because when she told me this kid was like, all the things she told me about this kid, I knew she wasn't just afraid. I knew this child really stood out to her in a very different way from other kids, and I think that will sort of show. So this is also a very unusual call. This is not my typical call, but I thought I would show you more of the need to triage. So this is a 10-year-old who had DeGeorge's syndrome, which is a genetic condition, which we'll talk about in a minute, had mild cerebral palsy and had a history of anxiety and depression. He had been on the wait list for mental health services, and they had started 10 milligrams of fluoxetine. So he came to her office, and his chief complaint that day was he was reporting auditory and visual hallucinations. He was talking about the devil. He was talking about demons and wanted to kill himself. He looked paranoid, was acting very, very bizarre. The parents reported that he had run out away from the house, started threatening to jump off the bridge. When the pediatrician saw him, he looked terrified. This wasn't just anxiety. He was suspicious. He looked scared. He was convinced the voices were real. And this was completely and utterly outside of what this child normally looks like. She was like, I couldn't even really understand what he was saying, almost describing that he looked disorganized. So he had actually gone to the emergency room for suicidal thoughts, but they had had trouble finding him a bed. And so they just safety planned him and sent him to the pediatrician to follow up. And she's like, this is not like that typical suicidal stuff and depression I'm used to seeing. So he was really talking more about the voices telling him to kill himself, and the voices were really the driving force on the suicidal thoughts, and that he looked very, very revved up. The family also had a history of autism and an older brother, but this was really, really different from anything that she had seen. There was no history of trauma or PTSD symptoms, which is often the cause of voices in kids. So it's important that we didn't have any knowledge of that. And she's like, I just can't even recognize this kid. He's not making any sense. And remember, this really is a different this is not the type of phone call I usually get from her. So this is one I actually arranged a super fast referral for child and adolescent psychiatry. I think I got them in 10 days. Kind of bent over backwards to make that happen. I said, stop that Prozac. And I'm going to tell you to do something I've never told anyone, I've never told you to do on the phone. This actually sounds like a true case of pediatric psychosis. Those voices actually sound real. You're reporting a severe functional impairment. And I'm going to tell you why that's likely. I told her how to dose it. I told her what labs to order, and I told her how to fill out the paperwork, because getting a Risperdal for a child with rational drug therapy is not an easy task. So she was able to do all these things, start the Risperdal. He was actually up to the 0.25 for a couple days when we saw him back, and it had helped a good bit. But this was a child who really sounded like they were presenting with true psychosis, which is incredibly rare. However, DeGeorge syndrome, which is a genetic condition that affects midline structures, can be cardiac effects, thymus, have a very high lifetime risk of developing psychosis. About 25% of kids with DeGeorge syndrome will go on to develop a psychotic disorder. So this was very much in line with his underlying illness and the presentation of true paranoia, not anxiety, disorganization. And then that component of it really being a command hallucination that was clearly not real, and he looked like he was responding to it, was not in the realm of what a lot of 10-year-old psychosis is. Most of the time when kids present with voices at 10, it's often imaginary or a developmental issue or anxiety or often trauma, none of which fit his clinical picture. So when we saw the patient back around that 2 mark, he already looked better. There was also some concern for mania. The parent said he wasn't sleeping. He was really hyperactive. So that went along with the presentation, but he was doing much better. The voices were getting better. He did not look nearly as stressed. He didn't feel like he had to act on the suicidal thoughts. And he hadn't been running away from the house trying to leave out of fear and being scared. And the parents were like, he's really looking so much better than he used to. We're getting our child back. And at that visit, we increased the Risperdal to 0.5 BID. And he really did stabilize over about a month. So again, only twice in the history of this phone line have I ever told a pediatrician to start Risperdal, but this was a pretty excellent case of that. So again, learning points from this one are that true psychosis is really rare. And most of the time, if you're calling about true psychosis in a 10-year-old, it's probably not going to be psychosis, because that's really darn rare before puberty, less than this one 0.01% before puberty. But usually voices are, again, more trauma, anxiety, or magical thinking development. But this patient had a clear underlying genetic risk. It also really highlights that not all suicidality is depression or a mood disorder. And kind of going back to our third call, when you talk about suicidal thoughts, that really helps understand what the context for the suicidal thoughts are. In fact, I wonder if anybody on this call, some of you have heard me say this before, but even depression is not the most common cause of a suicide attempt in kids. Does anybody know what the most common trait or diagnosis is in suicide attempts in children? It's not on the slide.
Feel free to unmute or chat in.
Oh, I'll tell you. It's ADHD, actually. It's the risk of impulse control. It's impulsively responding to an emotion. So it's really important we don't forget that. And this was, again, a case where suicidal thoughts were, he wasn't suicidal. He was having command voices telling. And then again, this was a really unusual presentation. Got to really validate the pediatrician that this is not a normal presentation. This is one that really needs that higher level of care. And I would have sent him back to the emergency room, although they had had such a bad experience in the emergency room. And it's very hard to hospitalize a kid under 10, and the parents were super duper responsible. So we went this way instead, and it worked very well. So again, just this is really not an unusual case, but this really is this is the thing the pediatricians fear. And I think having someone to talk about that with really was helpful to the pediatrician, because this was really where their anxiety would have not been helpful to anyone, because pediatricians don't know how to start Risperdal in a psychotic kid. And then I talked to her afterwards, and she's one I talked to a lot. She said how much better he looked, how much a family was grateful, and it was really the right thing to do. So just a couple of last things, just again, some resources. These are state resources. This is that crisis line we talked about. This is really that 24/7 call. This is actually, anyone can call this. Providers can call this to make arrangements, but this is a number that urges parents and kids to call themselves. If a parent and child calls my line, I give them this number, because this is really the number for families and parents as well. We now have statewide mobile crisis services throughout the state. They're by region. That 800 number, that crisis line can connect you to these services, but they're covered by different counties, and you can call them directly. There's a mental health wraparound project to deliver more intensive services in the home for out-of-home placement. And then some of you have heard me talk about the SED waiver, the serious emotional disorder waiver. This is the waiver that was created in 2019 for kids that really need significant services to include case management, community plans, independent living, in-home therapy, job support. These are for kids that are at risk of out-of-home placement from a significant chronic mental health condition to really help keep them in their homes. And then a couple more resources. As you can see, I put Psychiatry, our Psychiatry Echo on this, the PALS line. These are resources that really help clinicians build their skill set and provide services. But the WVU Mars line is also a service through WVU that people can call if they have an urgent question. And this is a 24-hour line as well. But these are all clinician and provider support services that you all are familiar with now, two of them. So wanted to share those as well. Does anybody have any questions? And I'm sorry, I couldn't see the chat. So
No, they're fine. That's what I'm here for. We also had Jerry say thank you again. Very interesting and informative. Although I am not in West Virginia, many take homes and ideas to try and move forward in my home state of Missouri. Thank you so much for that comment. And I agree, it was excellent. You provided great resources. It's great to know that it's here for everyone, and some great case examples as well, as per usual. Does anybody?
And sometimes they refer to PBS, folks. Like that sometimes is a referral too. So I'm sure there's probably some referrals you get from that program too. So a PBS.
Absolutely, we really appreciate it, Dr. Swagger. Does anybody have any comments or questions? Probably hear my dog panting, and I apologize. Trying to keep her settled. All right. Well, I only have one announcement, and the next session will be taking place on May 18th with Dr. Lillard, and she'll be discussing subpoenas, dispositions, and testifying in court. So we look forward to seeing you guys. Submit a case if you have time, and we really appreciate it. Thank you so much. Bye.
Thanks, everyone. Thanks, Dr. Swagger.